To start off, I think the fundamental focus of all modern spine surgery is based on two principles: to minimize access related injury, that is to minimize the soft tissue and bony resection, and to avoid unnecessary fusions by preventing iatrogenic instability. So full endoscopy right now is one of the fewer techniques in this current scenario where it is possible to fulfill these two criteria to the fullest. And this is possible because it provides a target specific approach. We have different approaches, two of which you know already, interlaminar and transforaminal. And all this is to avoid the bones and avoid the vital structures to reach the pathology and to treat the pathology with minimal damage. So all of us know that full endoscopy is an established technique for degenerative disc diseases, mainly disc herniations, stenosis decompressions, and recently I think fusions have also been come up. And the aim of this talk today is to focus on these other aspects of spine pathologies, infection, tumors, and deformity. And my job is to share our experience, whether it's possible for us to invade these particular pathologies. So let's start with the first one, a degenerative spine case. We have a 52-year-old female patient, severe right upper limb radiculopathy, bilateral sensory loss so severe that she got a burn on the hand and she was not able to feel it. There was severe out of proportion weakness of the right hand. If you see the disc herniation, it is not so big as to cause so much of weakness, 3/5 weakness, and there was no evidence of myelopathy. So we planned a cervical laminectomy by over-the-top decompression, and this is how we planned. We dock the cannula in the interlaminar space. Once the endoscope is inserted, some muscle fibers are removed to expose the V of the cervical spine. This is drilling of the superior lamina. This is drilling of the lateral part, the medial part, and this is drilling of the inferior lamina. The aim is to thin out the lamina so that the ligamentum flavum can be dissected off, and we can remove the rest of the lamina with the help of a tube sheath punch or a microkerrison punch. So the flavum is separated from all the sides. It is dissected off and it can be removed as a single piece, and this is what we found. There is a big disc herniation between the triangle of nerve root. This is the disc space, and this is the true nerve root which is hypoplastic, and this is the lower origin of the nerve root which is split into two, the sensory and motor aspect. And if you can see that it's a triangular nerve root where the disc herniation was in the center. This is the decompression of the opposite side by going under the spinous process, removing the flavum of the opposite side. This is the drilling of the base of the spinous process. And there you can see that the opposite facet joint. So this is the triangular nerve root which we saw, the congenital nerve root anomaly. And if you actually look at, this is what we see, that this was supposed to be the true nerve root which was hypoplastic. This is the inferiorly placed nerve root which was split into two, the separate sensory and motor component, and the disc herniation was lying in between these two. So these are the post-operative MRI pictures, and this is the patient mobilized in the same evening. There you can see on the right hand, she has got burn which she was absolutely not feeling. Her sensations returned back after a couple of months, and now still she is completely painless after almost 2.5 years of follow-up. Another case scenario, I think a central hard disc thoracic spine. All of us know that the standard approach for this is a transthoracic approach. And is it possible for us to do an endoscopic surgery in this case? I think we can avoid the morbidity of open thoracotomy by doing a small incision, retropleural transthoracic approach, where the cannula is inserted under the rib and placed over the rib head. Then the rest of the procedure follows the same. You have to remove the rib head, identify the pedicle, and you have to keep on drilling till you remove the entire disc herniation. So this is how this is the intraoperative pictures. No chest drain, 8 millimeter incision, and the patient can be discharged immediately on the next day. A third case scenario, very extensive epidural abscess in a 20-year-old male, severe back pain, difficulty in walking, power slightly reduced, And there you can see the abscess is originating right from S2 vertebra going up almost up to the L1 vertebra. The lower part is caseous tissue and the upper part is liquid. And we planned a right-sided interlaminar approach at L5S1 level for this case. And this is the procedure after the removal of the ligamentum flavum. You can see this is all caseous tissue which is being manually removed. And once that is done completely, you look for any other compression. So this is complete removal of the caseous tissue. And after that, we just inserted a small elastic rubber tube and we aspirated the abscess in the upper end. There you see the reach of the endoscope. Even though the endoscope is placed here at L5S1 level, you can see you can angulate it right up to the upper border of L5, and the tip of the probe is reaching almost the lower border of the L4 vertebra. So it's possible for us to reach from this area to this area, almost like this. So there is quite a big area which can be covered with an endoscope. And these are the post-operative MRI pictures. You can see there is complete resolution of the abscess and you don't see any evidence of any surgery anywhere. Another case, tubercular spondylodiscitis with a cold abscess. Now this is a funny one. We have a large iliacus or abscess, reaching the disc space, but it is not communicating. There is a gap in between. And what is the aim of the surgery? Biopsy, debridement, abscess drainage. And if there is a significant damage to the vertebral bodies, I think we can go ahead with fusion. So what I noticed is that when I went interlaminar, actually after completion of the discectomy or debridement of the disc space, I had to cut the anterior annulus. And once the anterior annulus was cut under vision, this is what we could, get. We could start draining the iliacus abscess, which was coming out, flowing almost like a river through the cannula. And I followed it up with bone grafts which were obtained from the iliac crest. I inserted it through the cannula and followed it with percutaneous screw fixation. So what about tumors? Is it possible for us to deal with tumors? One of my own cases, I've been with this patient for almost 15 years. 27-year-old male, when he was 16, almost 16 or 17, I operated him for a paraparesis of the lower limb with a non-Hodgkin's lymphoma mass in the lumbar spine. Went for chemotherapy. Then again there was a recurrence in the cervical spine. He came with quadriparesis at that time. Multiple chemos over 10 years. There was one incident where the failed chemo caused severe life-threatening condition for him, severe reaction to the last chemo. And the oncologist just said that we cannot give chemo anymore. And after that, after almost 1.5 years, he came with severe right anterior thigh pain. Where the oncologist had refused chemo and the patient had refused chemo. So what could we do for pain relief? So these are the MRI pictures. You can see that there is occlusion of both the foramens with the tumor invading the foramen. And this is what I did. Now the tricky situation in this case is that the anatomy is absolutely obscured. You don't know what is where. So the only friend of yours is the bone. You just land on the bone and you palpate. It's like entering a dark room with no lights on, and you just have to go with your gut feeling. And this was the final decompression of the nerve root. The patient became pain-free completely immediately after surgery, and I had almost 6 to 7 months follow-up. After which I think he developed some kind of complication, and he is no more. Now what about C1, C2 irreducible deformity? Is it possible? This was a case of C1, C2 dislocation, not reducible on extension. There was some weakness in the hand grip, unsteady gait, classical case of myelopathy. What are the treatment options? All posterior, all anterior, or the one which I like is the anterior release followed by posterior fixation. So is it possible for us to do that anterior release with an endoscope? So this is what we did. Approach C5-6 disc level, small incision, just enough to allow your little finger to go in, and you reach up to the bone, make a plane with a blunt dissection, then you insert the working channel. This avoids the problem of the high retropharyngeal approach where you are, about to dissect the digastric muscle, and this is the placement of the cannula, and this is the placement of the forceps. So this is actually the joint which I've, dissected up. This is the movement. Try to drill the lip of the lower vertebra, and this is the opening of the joint. I've inserted a dura dissector in between, just trying to open up. And before this, we had to cut the longest cola and the longest capitis also. And this was followed by a posterior fixation with complete reduction of the C1, C2 joints. So the take-home message is, full endoscopy is a sophisticated and a very highly evolved form of MI surgeries. It offers trifold benefits of illumination, magnification, and a clear field of vision. And it is possible for us to, take away some part of open surgery by doing endoscopic assisted procedures or approaches. So part of the surgery can be endoscopic and part still can be open surgery. And it is an excellent procedure to approach difficult to access areas, especially the cervicothoracic junction of the thoracic spine. And it has a huge potential to explore the use of endoscopy in pathologies other than in degenerative spine diseases. Thank you very much.